It's my great pleasure to welcome you to the launch of the Cataract Clinical Care Standard by the Australian Commission on Safety and Quality in Healthcare. My name is Liz Miles. I'm a general practitioner here in New South Wales, and I'm coming to you from the land of the Cammeraygal people. As well as my clinical work, I have a number of non-clinical roles as the Chair of Therapeutic Guidelines, a member of the Pharmaceutical Benefits Advisory Committee, and I'm also a member of Cancer Australia's Advisory Council. And over the past few years, I've also been working with the Commission on several initiatives, which include the Atlas of Healthcare Variation and other clinical care standards. I've seen very much how the work of the Commission is integral to coordinating safety and quality priorities at a national level. So I'd just like to begin with an acknowledgement of country, and in the spirit of reconciliation, the Commission acknowledges the traditional owners of country throughout Australia and their connections to land, sea and community. We pay our respects to elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander peoples today, and particularly to everybody who is of Aboriginal and Torres Strait Islander descent joining us on this webinar today. Just from a technical point of view, if you have any issues during the webcast, please click the help button at the top of your screen or contact Redback Support on 1800 733 416. And we are recording this webcast so that you'll be able to find it later. So we're here today to introduce the Cataract Clinical Care Standard. And as we know, cataract is a very common condition. As people get older, it becomes more prevalent. So from my perspective as a GP, cataracts are something that we often have conversations about, and whether surgery is going to be needed, and if so, how people can actually access that. There's no question that as people get older, things like the ability to drive really impact on a person's independence. So managing to get those cataracts treated is really important, and helping them navigate that pathway to care is sometimes quite challenging. So I'm actually very personally pleased to see that the Commission has actually taken on this work. So we might begin by introducing the panel. I'm joined today by Conjoint Professor Anne Duggan, who's the Chief Medical Officer at the Commission. Anne is also a highly respected gastroenterologist with significant leadership experience, who is passionate about improving healthcare services through collaboration. And she is a conjoint professor at the School of Medicine and Public Health at the University of Newcastle. So welcome, Anne. Thank you. We also have Tracy Siggins, who is the Director of Ambulatory Services at the Royal Victorian Eye and Ear Hospital. Tracy is an experienced operations manager who has been at the forefront of innovation at the Royal Victorian Eye and Ear Hospital for 11 years. Welcome, Tracy. Unfortunately, Associate Professor Andrew White is unable to join us today, but I would like to welcome Catherine Mancuso, who has stepped in at late notice. So thank you very much, Catherine, for joining us. Catherine is an orthoptist by training, whose substantive role is as the Manager of Diagnostic Services at the Eye and Ear Hospital. She's currently Acting Coordinator of Service Improvement and has also recently held the role of Manager of Planning and Patient Experience. Later on today, we will be hearing about the interesting case studies that the Commission has prepared to accompany this launch, which showcase innovative approaches to improving cataract care in line with the Cataract Clinical Care Standard. One of those case studies has been provided by the Royal Victorian Eye and Ear Hospital, known more commonly as the Eye and Ear, and both Catherine and Tracy have been integral to implementing the Eye and Ear's pathway and processes. So welcome, Anne, Tracy and Catherine, and we look forward to starting an important conversation about improving cataract care. So I'll begin by handing over to Anne, who is actually going to walk us through the new cataract standard.
Thanks, Liz. As Liz said, as we get older, we develop cataracts that start to impact on our ability to drive, to drive safely, to read and work effectively, or to enjoy life's pleasures that require visual acuity. We also develop cataracts that actually can make it hard to stay safe and avoid falls. Fortunately, cataract surgery is a highly effective surgery, so many people in need can benefit. And as Tracy Wilson says, our focus should be on patients. And what we should be doing is whatever needs to be done to address the issue of cataract surgery in an equitable manner. As I said, cataract surgery is effective. It's also one of the most common elective surgery in Australia. So if we get it right, we can actually help many, many Australians in need. As you can see from the pie diagram, most surgery occurs in private hospitals, but up to 30% of surgery occurs in public hospitals. So there are many members of our community who rely on efficient and effective services provided by our public services. What this pie diagram doesn't illustrate is there are many other Australians who can't access our services because of geographical remoteness or because of cultural factors that don't make services culturally appropriate and friendly. So there's a lot of work and a lot of pressure on the public sector to do better. But what we do know when we look at the key steps along the patient pathway, there are parts in the pathway where there's good evidence that done well, it can diminish waiting time and it can ensure that the wait is proportionate to patients' needs. So those most in need are more likely to get their surgery before those who don't need it so urgently. So we can provide a service that's much more equitable. Why is it important? Well, not all Australians can opt into private care. And if you look at admission rates to public hospitals, they are more than double in areas of socio-economic disadvantage. One of the most disadvantaged groups in our society are Aboriginal and Torres Strait Islander communities. Even if Aboriginal and Torres Strait Islanders live in major cities, it is quite clear from this slide that access to surgery for those who need surgery is less than their non-Aboriginal Australian counterparts, 62% versus 86%. So there's work to be done there as well. So how can we make patient pathways to cataract care better and fairer? Well, that's the role of the Cataract Clinical Care Standard. Why a standard? Because we know that there's evidence out there of how we can do far better. The Clinical Care Standard is designed to support the delivery of consistently appropriate evidence-based clinical care. It provides guidance on the organisational systems that we can put in place that will drive quality improvement. And it promotes what is incredibly important in healthcare, shared decision-making between patients, carers and clinicians to ensure the best outcome for all. The Clinical Care Standard focuses on the areas where there's evidence, as I said, that we can do better, and by doing better, we will make huge gains in the provision of cataract surgery for all Australians in need. What we know is that efficient, effective and equitable care is driven at the beginning of the journey by taking the right first steps. Improved referral processes, improved assessment processes in our hospitals, and that relies on local protocols that are actually driven by evidence and also informed by high quality referrals. That enables us to develop systems that are prioritising our resources based on needs and are consistent throughout. Now, here's a slide of the 8 quality statements. And as you can see, it's focused on key areas. And you'll see number 6 also focuses on second eye surgery. And as Liz will know, the timing of second eye surgery is incredibly important also for patient care. And it also focuses on post-operative care and how we can do that better. But I just want to take for a moment the areas where I think we really can start and get quick wins. Primary care assessment and referral. As a clinician, I know at times I've received referrals which have just said, please do the needful. It's really hard to effectively run a system and ensure that you're providing a service when a referral isn't providing all the information required. The GP and the optometrist play critical roles in providing really important information about visual impairment, how that visual impairment is impacting on that person's activities and the things that they need or want to do. A GP plays a critical role in providing the information about comorbidities, which is an important factor in considering the risks and benefits of surgery. And it might be extraordinary to know that it is incredibly important that a conversation occurs in primary care about the patient's willingness to have surgery. The literature shows that people at times turn up not knowing why they're there, and when the issue of cataract surgery is discussed, it's not the right time for them. They don't want it now. What an opportunity cost that can be rectified. The second area that we can make difference is in access to ophthalmology assessment. With locally developed and approved protocols, there can be a consistent, appropriate approach to referral based on clinical need and informed by a high quality referral. Together, this information and this assessment will allow us to prioritise access to surgery based on patient need, on knowing what the impact of their visual impairment is currently having, on the harms of delay, knowing about comorbidities to tailor surgery if need be, and also to inform the expected benefits so that informed discussion about risks and benefits can occur with the patient. I want to touch on just one other area of the standard, which I think is very important. And you'll see from the case studies how One Health Service has made such a difference to improving the use of antibiotics. What we know from the evidence is that routine post-operative topical antibiotics, and I mean routine, aren't based on evidence. There's clearly clinical indications, but when we are moving into a world of antibiotic resistance, there is an onus on us all to be thinking about how we use antibiotics and ensuring that they're appropriately used. So how do we start? Well, we start standing on the shoulders of giants. We've got some great case studies and we've got a great discussion coming up, talking to people who have made a difference and continue to make a difference. And I hope you'll take the case studies together with the other materials we've provided on our website to start the journey. So I go back to my question, how can we make patient pathways to cataract care better and fairer? Let's start with better referral processes, better triage and prioritisation, and we'll end up with a much more patient-focused pathway that addresses the needs of all Australians. Thank you.
Fantastic. Thanks very much, Anne. And that's a really great overview as to the purpose of the clinical care standard, and particularly in driving equity and efficiency for patients seeking to have their cataracts done. So I might just now go to Tracy and Catherine. So you were both instrumental in the streamlining of the patient care pathway for cataract at the Eye and Ear Surgical Ophthalmology Service. And I think you're also going to tell us a little bit about the collaboration with the Victorian Aboriginal Health Service and a great model that you've developed for improving access for Aboriginal and Torres Strait Islander people in a culturally safe way. So Tracy, perhaps you could start by telling us about the Eye and Ear and some of the challenges that it was facing.
Thank you, Liz. The Royal Victorian Eye and Ear Hospital is the only eye and ear specialty hospital in Australia and the only specialty eye hospital in Victoria. The hospital's specialist clinics see approximately 170,000 patients per annum, and of these, approximately 80% are patients seeking care within our ophthalmology clinics. The hospital also has an important teaching role for the ophthalmology teaching program, both within Victoria and also nationally. The highest volume surgical procedure undertaken at the hospital is cataract surgery, as Anne previously mentioned. In 2013, so approximately 7.5 years ago, when we first started our journey, as I will call it, we identified 4 key issues. Firstly, there was a concerningly increasing amount of time that patients were waiting to be offered a first appointment within our general eye clinics for consultation and review of their cataract concerns. We also noticed that there was inequity with wait times across the then general eye clinic structure for these patients with regard to both clinic and surgical access. There were a concerningly low number of patients on our elective surgery waiting list, and that was concerning because of our important role in teaching the new generation of ophthalmologists. We also noticed that a high number of patients attending for their first visit within our clinics were, for a range of different reasons, not actually being consented for surgery at that initial visit. And so our journey began. So what did we do?
Yes, can you tell us a little bit about that?
Yes, I will. So what we then did was really look at what the evidence, both nationally and internationally, was telling us. We looked for experience across Australia and also within our partner or our similar eye hospitals across the world. We started with really revisiting our referral guidelines, which we had in place for a number of years, but which obviously needed some tweaking because of the large number of patients who were attending their first clinic visit and not actually converting, as we call it, to surgery at that particular visit. So we revisited our referral guidelines and made them a standardised approach and a standardised format. Alongside this, we created a triage process, a consistent and standardised and mandated triage process for every referral coming into the hospital needed to be triaged by one of the triage clinicians. The pathway that we created or developed for our surgical ophthalmology services had a consistent approach in that every patient's first visit was undertaken with an assessment, with a diagnostic suite being undertaken, with pre-admission processes being discussed with that patient, and also with the patient being consented for surgery at that particular time. The patient then continued on their surgical pathway. Post-surgery, again, there was a very consistent approach for how those patients were managed. There was a consistent approach to the day 1 post-operative appointment that we very quickly introduced or converted to a telehealth appointment. We identified that the vast majority of those patients didn't really need to represent to the hospital, and so most of those patients to this day have that day 1 post-operative appointment via telehealth. And then again, the second post-operative review that's generally undertaken in week 3 to week 4 included a standard, consistent approach to that visit, including at the time of when we first introduced our pathway, the patient having a discussion and being consented for their second eye surgery or being discharged.
Fantastic. So what was the outcome of all of those changes?
So I'm actually going to throw over to Catherine to talk through this particular slide because again, she has been hugely involved in this work with me.
Okay, great.
Thanks, Tracy and Liz. Yeah, you can see from this slide we had a massive improvement, 79% decrease in patients waiting for their initial assessment and 90% decrease in the longest waiting time. And that obviously has huge implications for patients. They come to their primary caregiver with a problem. That primary caregiver identifies that they need assistance at the India hospital. They make a referral. Those patients get really quick turnaround time to come in and see us, have their assessment, and then have their surgery. And it's a fantastic outcome for our patients.
That is really impressive. I mean, those numbers look extraordinary, really. A 79% decrease in waiting time for assessment and 90% in the longest waiting time. Can you expand a little bit, Catherine, on just exactly what those changes mean for patients?
Yeah, so we find that we have a mix of referrals coming in from our GPs and from our optometrists and from our private ophthalmology practitioners in the community. And those previously, those referrals had been of varying quality. And by tightening up our requirements for the information that's included in those referrals, and also tightening up the way our staff approach triage of those referrals, we found that the patients who are coming through in a really timely manner. It's not uncommon for the majority of our patients to be seen within 6 months of their referral in our outpatients clinics. And those patients are then, because of the timely turnaround for their first assessment, are much more likely to convert, as Tracy referred to the surgical wait list. So they've come, they've had a problem, they're thinking along the lines that they do want to have their surgery undertaken, and they are seen in the right place at the right time by the right people to have the right care, and it makes such a difference to our patients.
Yeah, oh, thank you very much. I mean, that is such a great outcome. So the clinical care standard does focus on referral assessment and prioritisation. And certainly as a GP, I'm interested in knowing when to refer and how changing referrals could make a difference. So it's not always transparent to us about when we should be referring or what even happens to our referral once we do it. It can sit there for an extremely long time. So I might go to you, Anne, and just get you to talk us through why the standard has a focus on referral.
Well, I think the evidence shows that the quality of the referral, as Catherine has said, really either ties the hands of the health service or facilitates the service putting in place appropriate triage. I think all Australians believe that it shouldn't be a first in, first served system. We should be providing resources and access based on consumer need. And so I think referral from that point of view is a good referral is really important. And I think we should value patients' time. If you haven't had a conversation with a patient, and in fact the patient does not want cataract surgery at this stage for whatever reason, then the time for them to have that conversation is, I think, with the primary care physician, not wasting their time going to appointment, perhaps taking their day off from when they're self-employed, so it's a huge cost to them, to have that conversation and say, yes, but not now, I've got other priorities. And I think the other thing is that with the clinical care standard, while we're focused on referral, we do emphasise the importance of locally developed definitions of what appropriate is. Not one size doesn't fit all. It's a great opportunity for primary and secondary care to get that continuity of care working really well, as they've done at the ENI.
Yeah, so it's certainly, I mean, I know as a GP, it's always really good when you know what the criteria are. I might go to you, Tracy and Catherine, just to get you to tell us about how you addressed the issue of appropriate referral.
So I'll start, if you like, and Catherine, you can jump in. So Liz, As I mentioned in my introduction, back in 2013, 2014, we were identifying that large numbers of patients or new patients were coming into clinic and accepting an appointment to come into the clinic. I think sometimes people saw it as a lovely day out to come out to Ioneer Hospital. And once they got into clinic, for a large number of reasons, they weren't actually at that time appropriate to be consented for surgery. And some of those reasons were, interestingly enough, sometimes they'd already had their cataract surgery done elsewhere. Sometimes the patient indicated that they were interested in cataract surgery, but not right now. Sometimes patients thought that there was an extraordinary long wait, and certainly at the Ioneer at one stage there was a very long wait for surgery, and so they just wanted to get their name onto the waiting list. And sometimes the individual didn't meet our threshold criteria to be at that particular time consented for cataract surgery. So what we started, sometimes also patients were coming in without the appropriate diagnostic information that really informed and assisted to make that decision with the treating team around the degree of that patient's clinical condition. And so our referral guidelines aimed to be able to provide that information to referring clinicians, be it GPs or optometrists. We designed them to be transparent and to provide all of the available information around what needed to be provided with that referral when it came in. When the referral comes in to our triaging clinicians, who are our ophthalmic team or our applicable credentialed orthoptic team, they will then review that referral and ensure that all of the applicable information is available for them to be able to actually identify and prioritise from a clinical perspective the priority of that particular referral. The referral is either then accepted and is assigned a clinical prioritisation, urgent or non-urgent, or the referral is rejected, or sometimes the referrals are sent back for further information.
Oh, it's very interesting. I'm certainly interested as a GP to know, how did that go down with GPs and referrers when you introduced these new criteria?
Yeah, Liz, it was challenging. It was challenging because there had been a long history of the idea accepting patients where the referral letter read, "This patient has a cataract, please do the needful." And so having a history and a practice that needs challenging is always a challenge. We had some difficult conversations with some of our referrers, and I had personal phone calls from some of our referrers saying, "Why aren't you taking a referral? Why are you rejecting my referral and saying I have to send my patient elsewhere to get more information?" But once you had a conversation with the referrers and explained that it's not a slight against you, it's not a slight against your patient, this is about providing the right care at the right time by the right people, it was well understood, and a slow but steady process was put in place. And now the quality of the referrals that come through are what we need. They are high quality referrals. They tell us the information that we need to know to be able to provide the care and the timeliness of that care for our patients. Okay,
fantastic. So Tracy, what else has the Ioneer done to streamline the processes, and what were some of the main changes in assessment?
So probably the single greatest change that the Ioneer did was in 2014. We restructured our then general eye clinic, clinical or group of clinics, five different general eye clinics, and established two very specific pathways. The surgical ophthalmology service, which is predominantly for patients seeking and being treated or having treatment for cataract, and also the acute ophthalmology service, which has a very close alignment with our emergency department. So once we had the surgical ophthalmology service in place, we identified, we worked through a whole process, and this is where I think the importance of having access to applicable data and data sets cannot be underestimated. We wanted to align and have, as Catherine's already mentioned, very efficient and a very streamlined flow for patients who we receive their referral, we triage their referral, we waitlist those patients. We want them to stay on the waiting list for definitely under 365 days. And we have identified through review of our data that for a patient who stays generally on our waiting list for 6 to 9 months, will generally accept a referral at the first offer and will generally at their first review or their first consultation appointment convert to surgery. So in order to have that very streamlined process, we needed to identify how many surgical ophthalmology services, consulting clinics we needed to run each week. We needed to identify how many post-operative clinics we needed to operate each week. And it was in the post-op review field or area that our next improvement was identified. Because what we found was that we had delivered such an efficient pathway, and so many patients were having really efficient surgery with a relatively short waiting time between consent for surgery and having their surgical episode, so approximately 4 months at this moment in time, was that our post-operative demands were very high. It was at this time that again we started working with the Surgical Ophthalmology Services Head of Clinic, Dr. Anton van Heerden, and Catherine's team, and developed our orthoptic post-operative review pathway, whereby a group of orthoptists have been credentialed to undertake that week 3, week 4 post-operative review. We also are now quite recently identified that orthoptic post-op review clinic is really excellent, except for when a patient comes in there who needs to be consented for their second surgery. So we've now also developed a bilateral consent process that happens at that first initial visit when the patient is being consented for surgery.
Great. Okay. So that's fantastic. So interesting to hear about the credentialing of orthoptists. I know that the Commission has also has some case studies that look at additional training and credentialing of nurses, with the Westmead case study providing an excellent care example. I'm just wondering, Anne, can you just tell us, is the standard recommending that health services implement the standard the same way as the eye and ear?
No, definitely not. I mean, the aim of the standard is to meet the needs of all Australians and support all health services to provide the best care they possibly can within their resources. So the standard articulates what good looks like, but strongly recommends that just as the eye and ear localised according to their needs and their priorities, then health services should look at how they're doing, look at the clinical variation from what best practice looks like, and that's why we've got indicators to measure how you're travelling, but localise according to needs. And I know that one of the issues that I think is very important is, as I mentioned in my talk, that we should be localising how we do it for the most disadvantaged groups in our societies. So Aboriginal and Torres Strait Islanders have a bigger need. We need to make sure that every time we think about the standards, that those in charge, clinicians, health service managers and consumer groups, are thinking about how best the standards can be implemented locally. And then if we do that, then the results will be much better and more appropriate to that community and meet the needs of that community.
Yeah, so it's good that you raised the issue of particularly Aboriginal and Torres Strait Islander people. So we know that in terms of disparity in access, that they really have a huge disparity and issue with equity. So I'd just like to go to you, Catherine, just to ask about the very successful collaboration between the INE Hospital and the Victorian Aboriginal Health Service. And if you can just give us some pointers on how we can actually improve care for Aboriginal and Torres Strait Islander communities.
Thanks, Liz. Yeah, look, the INE Hospital has had a partnership with the Victorian Aboriginal Health Service for some time with our Healthy Ears clinic, which is run as an outreach clinic out of Vars in Fitzroy. And so we saw how there was an opportunity to be able to partner with Vars and provide eye care where we had been providing ear care for Aboriginal patients in an environment that was familiar to them, a culturally appropriate and safe environment. And that's critically important to be able to provide care for Aboriginal and Torres Strait Islander people. So it was a really exciting opportunity for us to be involved. And what it really did for the INE Hospital was really promote the importance of providing training for our staff in the area of cultural awareness and cultural safety. And I think indirectly as an outcome, we now have policies and procedures in the hospital where it's mandatory for all of our staff to be trained in Aboriginal cultural awareness, which is fantastic. This not just promotes that cultural safety when our practitioners are working out of Vars, but also provides an element of cultural safety when Aboriginal patients need to access care in at our main site.
Okay, so I guess in the last few minutes, I would like to go to each of the panellists and just ask them what their one take-home message is for the audience today and what they can do to implement the standard and encourage change in their own health services. So I might go to you first, Anne.
Well, I suppose for me, the most important thing is just reflect on where you are and where you want to be and just start the journey. It's like, how do you eat an elephant? A bit at a time. And use the examples that are out there and localise it to the needs of your community. And reduce unwarranted variation so that we're doing useful activity and using our resources wisely.
Great. So
benefit of the population.
Excellent. So very much starting from where you're at and looking locally to how you can improve things. Okay. So I might go to you next, Catherine.
Yeah, thanks, Liz. For me, as an orthoptist, as an allied health professional, it's critically important to be collaborative and work with all of the experts in the area. So that's GPs, it's optometrists, it's ophthalmologists, it's clerical staff. Everyone has a role to play, and when we pull together, we really do make differences, make a difference in the lives of our patients.
Excellent. And Tracy?
Thanks, Liz. So I suppose as the operational director responsible for this piece of work, for me, one of the key messages was, so how do we know if we've got a problem and how do we know if we're impacting on that problem? And that is, again, the availability of good sound data that you look at on a really regular basis. So we review our data every week, and sometimes I think I drive my team mad doing that, but it really was about being able to identify that there was a problem to start off with by seeing those very large numbers, and then by reviewing that to be able to monitor our progress, to be able to identify where we needed to make tweaks, where we needed to make changes, and where we needed to be at a certain point where we could look at further improvements. So the importance of data, meaningful data, can't be underestimated in assisting you on your pathway to improvement.
Great. Okay, well, that's excellent. And I guess from my perspective as a GP, you know, I've really taken on board the quality of the referral as being very important at the beginning of this journey. And so I know we have had lots of discussions with ACI New South Wales, but also with our primary health networks about how we can get messages out to GPs about what is required and the importance of that two-way communication and the feedback to the GPs to help them actually meet your requirements as well. So that concludes our discussion, and I hope that you've heard in our discussion today some insights that are relevant to your own organisation and some ideas to take back and trial without having to reinvent the wheel. We're going to finish with a video from Professor Phyllis Marshall, AC, who's the chair of the Commission's board, to officially launch the standard.
As chair of the Australian Commission on Safety and Quality in Healthcare, I'm acutely aware of the challenges facing Australia's healthcare systems today. Never before has there been such a pressing need to ensure our health system is providing the most efficient and effective and equitable care. This standard supports high quality care for consumers needing cataract surgery. It emphasises the active participation of consumers in their care, and that care should be based on high quality transfer of information from primary care to specialist, equitable triage and safe surgical management. Today we have heard some inspiring examples of clinical teams and service managers rising up to the challenges in their field of cataract care. My sincere thanks to the panel. I also want to acknowledge with thanks all of those who have contributed to the development of the clinical care standard. I'm confident that it will be of great benefit to the Australian community. I would like to challenge eye health clinicians and services across Australia to consider what the standard means to you and what you can do to improve cataract care. I'm pleased to officially launch the Cataract Clinical Care Standard, and thank you all for joining us today.
So that brings us to the conclusion of today's webcast. I do hope that today's event has given you food for thought and some ideas for going forward with the significant new clinical care standard. Just remember that you can look at the standard to find out how to go about implementing change at your health service and to the case studies for some real-world examples. I'd invite you to explore the Cataract Clinical Care Standard on the Commission's website. And I'd really like now just to thank our panel. So Tracy and Catherine, so inspiring to hear about your work at the Ioneer, and thank you very much for sharing your insights with us today. It is a timely reminder that there are many learnings along the way when you change the health system, so improvement is actually a continuous process. And thank you very much for helping us to understand the process, the intent of the standard, and why it's so important for the future of cataract care. I would also like to echo the sentiments of Professor Marshall in offering thanks to all the clinicians, consumers and policymakers who have helped us to develop this standard. And finally, I want to thank all of you, the audience, for joining us today. I hope you've enjoyed today's webcast, and I invite you to complete a short survey to provide us with feedback. The link will appear on the screen at the end of the webcast. Thank you.